I am doing, whatever I am doing today, I believe me, I dedicate it to Dr. Call after Allah. And after, because you see, the thing is that sometimes you get the path from someone. Okay. So if, for example,
Exactly.
on a weekend, if I am sparing time for others, believe me, my main impulse is Dr. Call, because I have seen him at age of 70 plus. He used to teach us in scorching heat of Pakistan in May, June, for example, sitting after he was the boss. Why he used to stay at 3 o'clock? Because he never used to take class during during the working hours. Okay, so he used to let us stay there over there, and after we finish our duty at 2 o'clock, we used to stay with him for 1 to 2 hours for the preparation of FCPS part one. Can you believe this? I have got
Yeah.
that person, and you are talking about
Although,
Dr.
although,
Tanveer.
uh,
Dr. Tanveer
Dr.
is
Zishan,
only one of them. Okay, I have seen even bigger names that with whom I did work at that time. Dr.
I,
Kashif Rafiq,
no, no, Dr.
Dr.
Zishan, you are
Babar.
taking me wrong. You are taking me wrong. Sorry for
So the topic for discussion today is that how to revise for any exam. Okay, any of you is going for exam now? Is it Amna, ABG, Dr. ABG? Is it you, Amna, or is it Jamil? Is it Jamil?
Ji sir, it is Dr. Amna.
Okay, so Amna, just share your experience before you appeared in the exam. So I will just make you the main lead, and Mahjabeen, you can also help us, because you have done just recently FCPS Part One. Because sometimes people are more concentrating on the previous exam pools questions. The previous they were they so in our medical college we used to say UQs, university questions. Okay, so the same old pattern which is there since our even grade 10, grade 12 time. Okay, so the thing is that is, yes, that is perfect. But I think the better way to revise before, if you are having two weeks from now, I think, not 2 weeks, I think 10 days or 12 days from now for the exam. So I will just suggest few of the things which you should do at this time. That you just divide the course, you make a list of the units or the subjects which may be there in the exam. Okay, and just divide them in the days which you have. Okay, and just try to revise the main buzzwords, the main points which may be the point on which they will make the question. Okay, so, like for example, if you just dedicate one day for gyneops, because gyneops, pediatrics, cardiothoracic, ICU, pain, regional anesthesia, liver, kidneys, and you can name on orthopedics. You can make a list of what whatever sorry, whatever topics they will be asking you will be, for example, if you just give an example of gyneops, so the question will be rotating around the physiological, pharmacological, and anatomical changes. Okay, so you should be knowing at what time that physiological change starts, and when it peaks, and when it returns to the normal. Because whatever the question will be number of which will be focusing, the base may be on the physiological change, what time it starts, what time it is there at the maximum, and what time it reverts to the normal. Okay, you will find a number of questions on the basis of this thing, or that may be a base of a question from which they will be giving you more data than this one. But this is one of the things which you should be revising, that how much is the percentage change in specific thing, when it peaks, when it starts, and when it comes back. So this is one of the point I will suggest you to revise when you are revising gyneops. Number two, I will give you second number will be, I will giving you labor analgesia. Okay, so a number of questions may be revolving around all the maneuvers, all the ways by which you can get the labor analgesia. First of all will be the what is the extent of block you need for first stage of labor, and then for second stage of labor, what are different options, how you combine them to make a plan. Then what are the pros and cons of each technique you are using, how to do the troubleshooting, like if there is some deficiency, how will you conquer, how will you first of all diagnose that what is the problem, is it patchy, is it complete failure of that thing which you are using, it may be epidural, it may be like any option which you are using. Okay, so then you will be assessing and then you will be do the troubleshooting. This point, there are a number of questions which can come. This is point number 2. Point number 3 will be, for example, if related to PIH. So some of the questions may be easier level will be on the diagnosis, but usually they will give you a scenario and they will make you understand that which stage of like seriousness it is, or which stage of pregnancy it is. And then on the basis of the point that there are 2 lives and you have to maintain a balance, and then you have to manage that patient towards the betterment. The priority is given to the mother. Okay, and then there are targets of control of blood pressure, control or prevention of fits, and delivery of the baby. Okay, so according to these points, and the priority is given to the mother, this is the points, and the therapy which is you are using for the management or prevention of fits, that may be magnesium, that may be diazepam, that may be any anti-epileptic, because that may have some implications with the anesthesia. So whatever question they will be asking you, it will be either according to the pathology, what stage of complication you are in, and what will be the first choice, what will be the second choice, what will be the third choice for the management. What is why you, in which patient you will not use the first choice, you will go to the second choice, like this. So this will be, or they will be giving you a scenario for any end organ complication which has occurred. What will you doing, what will you be doing at that time? Maybe there is the question maybe on HELP syndrome, the question maybe of eclamptic fits and leading to airway collapse. So this is one of the most important point on which they will ask you a question. So if you just try to recall all the steps, all the guidelines, all everything related to it, you might find a question out of that. Then another topic from Gyneops will be, for example, maternal hemorrhage. So whatever are the causes of maternal hemorrhage, and I will make it with maternal hemorrhage, I will add maternal collapse overall. Okay, maternal collapse, and one of the cause will be maternal hemorrhage. So they will give you a question in which there will be a maternal collapse in preoperative or intraoperative or during intraoperative or postoperative period. And they will be giving you a scenario, and there will be some hint about, for example, whether it is a patient related cause, whether it is pregnancy related cause, or whether it is anesthesia related cause. Okay, so patient related, maybe patients have some cardiovascular, neurological, electrolyte, or whatever the basic any disease of the patient which is leading to that collapse. And the pregnancy related, maybe uterine rupture or eclampsia or uterine rupture or anything like that. Okay, and anesthesia related, maybe pregnancy related also amniotic fluid embolism. Okay, so I'm just giving you an idea. There will be some hint of the reason for maternal collapse, and they will be asking you what to do. And the basic management, as I have discussed many times, that basic management is on the basis of airway, breathing, and circulation. Okay, and you will be targeting it, and then you will be approaching the patient. Okay, and according to the information they have given, you will try to find out the best possible management or best possible cause. Okay, so and then any question from Gyneops, maybe any disease in pregnancy. Okay, any disease in pregnancy. So it may be cardiac disease, it may be any neurological problem, it may be myasthenia gravis, or it may be any surgery which is required during the pregnancy. So you can just make a list, and if you are talking about surgery, the surgery will be, the main points will be the physiological, pharmacological, and anatomical changes, which I have told you before. And there will be some implications on the basis of these changes on the management of the anesthesia plan, that we know that what are the different steps, how to proceed, because usually the obstetric emergencies you have to proceed. Okay. Or for example, if there is any acute emergency in pregnancy, you have to outweigh the risk versus benefit, whether you can delay that surgery or not. Usually the general rule is that you avoid in first and last trimester, and you try to do it in the second trimester. That is relatively safe period. That is for any surgery which cannot be delayed till the end of the pregnancy. Okay. Otherwise you will try to postpone it till end of the pregnancy. So this will be the basic theme, and then interaction of the changes with the conduct of anesthesia. Any question will be coming on the basis of this thing. And if you are talking about disease, so you have to see what disease is, basic pathologies, any relationship with the of that disease with the physiological changes in pregnancy, whether they are it is increasing in frequency. Like for example, if the patient has cardiac disease and now that patient is becoming pregnant, valvular disease or any cardiac failure or anything, like patient is hypertensive to start with, and now patient is coming for now patient has become pregnant. So there will be certain things, you may be changing the medication which the patient is taking and things like that. Okay. So like I'm just giving you an example that this is the way to revise. I've given as an example of Gyneops. I have just given you example that how you should be revising it, because whatever question will be coming. Now I will take few minutes from Amna to tell me one thing, that just if you give an example that if you can recall any question which came to previous exam from Gyneops.
Yes, sir. There were several questions which came from Gyneops, like the cardiac output, when it would be highest or on highest during which period of the during which period, like in after delivery, during delivery, or after several weeks, like इस तरह का एक सवाल था. और इसके
Okay.
अलावा ये है कि
That's
how
what I was highlighting you. Okay. So
जी,
I think if you recall that whatever points I have told you, the questions were from one of them. Am I right?
yes, yes.
So that is my message, that when you are revising it, try to look, like just scan the pages and try to get the buzzwords, like any classification, any dose, any like guideline. Okay. Any like in anything in which this is that is first choice and that is second choice. So that should be in your mind. And Mahjabeen, because you are now starting, for message for you will be that you study like that. Okay. Whenever you are reading a topic, you prepare yourself that try to find the buzzwords, try to find the important things which you should know. And I guarantee you that if you open up your mind and don't try to read each and every line, rather than that, you try to check the questions which are coming from that topic before. You can see Google, you can see through SAQs, you can see through MCQs of that unit, and then you will you will get an idea that these are the important points which may be asked from that topic, and then you can retrospectively you can prepare them. Am I right? So that is the message which I'm trying to.
Yes, the book problem oriented, I have read some of the pages of it from respiratory system, and I think that's good enough to tell you about the questions which can be asked.
But
Am I
I will
right?
suggest you are absolutely right, but I suggest you Morgan, problem oriented, Oxford, Atkin Head Smith, Stalting, Miller, Barish. I can give you examples of books, but I guarantee you all of them are crap. If you are just trying to cram the words, or if you are trying to follow on only a one book, mark my words, because the thing is that that book is only trying to follow the pattern which the author of that book has followed. It is never giving you the perfect coverage for you as a clinician. Unfortunately, because if someone tells like this, there is a smile coming, there is a surprise coming, that how it is possible for someone to see all these books as crap. But I stand by my words. The thing is that because before maybe 100 years ago, there was no other way to study. Okay. But now you are not bound to reading a hard copy of a specific book. Okay. You have to extract, like I will use the word that you have to roam around like a honeybee, and you have to try to extract the honey, not from you have to become lazy and just put some sugar in front and make honey from that sugar. That's not the correct way. You have to roam around and then you have to make your own honey. So the best way will be that you just scan through a number of sources and make your own buzzwords, own points, own source, make your own notes. That's the only solution. You cannot follow anyone else's notes, believe me. It is just like you cannot wear anyone else's clothes, you cannot use anyone else's things. It's just like that, because that will be fitting to that person only. The best source for the covering of any topic is articles, the review articles. There is no replacement, I tell you, because I'm telling you with conviction. Because unfortunately, it is difficult to convince a person who is working exclusively in Pakistan or India. It is really sometimes difficult to make them convinced, because everyone is saying, sir, please, there should be a base book. You don't need any base book. You are not in class 5 that you need a base book. And I guarantee you, Mahjabin, because you are just starting the training, just tell me one thing.
Yeah.
Anything which you are reading now, anything which you had never ever in your career read before.
Nowadays, the head of department sends us review articles every week, and then he discuss with us that review articles.
Yes. Where are you working?
I'm working here in Ibn Sina Hospital, Multan.
Okay. Anyways, so I just want to give you a hint that the review articles are the best source. Okay. And I will suggest
Yeah.
you that you whenever you are reading a topic, even if you want to follow a book, you should be looking at the review articles. And if you have read them and then you read the text, it will be easier for you to swallow, rather than if you are reading the so-called Morgan, you will not understand anything. You will not be able to recall anything. Okay. So actually, I just wanted to tell you, and another thing which is important point, that if you have covered a sub topic from head to toe, and you know all the aspects, and you have first of all dig into that topic, that what are the points which may be asked, that is your solution, your problem has solved. Okay. And then that question, maybe even if it is asked in an MCQs, even if that topic is asked in oral part, if you are able to explain. Okay. Like I will quote the word of we were naming Call associate, so I will name again Dr. Call. That Dr. Call one day said a word, that if you read a page and you are able to make a MCQ out of that page, that then you can say that you know the subject. Okay. Whenever you are reading something, try to make a question out of it. If you make this habit, I guarantee you, only then you will say that I know the topic. And another thing is that after one day, you try to tell any other person who is standing next to you. If you are able to explain that topic which you had read before, maybe two or one, not next or last night, maybe 1 or 2 days before, if you are able to explain that topic to that person, then you can say that you know the subject. Okay. And that's why that's the motto which I follow. The best way to learn is to teach. Even if you know one word, teach it. You will never forget it. Even that person don't understand or not understand or don't understand, at least you will never forget that topic. Okay. So that's what I wanted to tell. And you make, yes, there will be a little difference in the scope of some exams. Some exams will be asking you more of the basic sciences, and some exams will be asking you more of the clinical sciences, but the basic theme is the same. For example, if you want to read cardiovascular system, you should be starting from how the cardiovascular system work. There is a heart, there is
Yes,
a
from the
vascular
very
system.
basic.
From the very basic. How can you jump it? But with an objective. Don't try to cram. We will be starting tomorrow night, 10 p.m. or 9:30 p.m. We will be Pakistan time. I will be sending the link, and we will be starting cardiovascular system. So basic thing is that if you want to study cardiovascular system, and first of all, if you want to have an evaluation of the cardiovascular system, you should be knowing the basic physiology. Like you should be knowing
Yes.
how the cardiac system work. There is one electrical system, there is one mechanical system, and then there is one vascular system inside the heart, which is giving the energy, okay, to the heart, like blood, for example. And then there is a nervous system of the heart. How the heart is, because if the nerve control is gone, how the heart will work. There are certain doors in the heart which are opening and closing at certain time. If you don't know how the heart is, when certain door is opening and certain door is closing, and when certain chamber of heart pressure is increasing or decreasing, so that's the first thing which you, because that will be base of all valvular heart disease. That will be the base of all cardiac failure. That will be the base of how to monitor, like what information you are getting from CVP, what information you are getting from pulmonary artery catheter, what information you are getting from cardiac cath. What will be the changes in the pressure, or the symmetry of the movement of blood from one chamber to the second chamber, and from the lungs to the heart, or from the periphery to the heart. Okay, so that will be, if you don't know the normal physiology, how can you understand the abnormal physiology or pathology? Okay, so that's how you should be correlating. Yes, you are not giving exam of physiology only, so you don't have to do PhD in physiology. Now you have to just extract the clinical part. What is the implication? What is the implication? What is the implication? Okay, so that is the message. And before that, you should be knowing what are the cardiac symptoms. Like any problem ends in up having either dyspnea, chest pain, edema. This is symptom anywhere. Or if you are talking about any problem because of ischemia, it may be a limb ischemia, it may be brain ischemia. Okay, or if it is heart ischemia, there is pain, or it has become resulting in any arrhythmia, you will have palpitation. And if it is failure occurring, like ischemia is so much that one of the chamber, like left ventricle fails to contract, it will be starting as regional wall motion abnormality. Then it will be reaching towards hypokinesia, and then akinesia, and then failure of the heart to maintain the circulation. And then patient will have the final sequelae, either in the form of cardiac arrest or in the form of residual decrease in cardiac function, if you happen to if the patient happen to survive. Okay, so this is the symptomatology. You are not doing research in like a medical student, but you have to extract the basic knowledge. Okay, so that will be from symptomatology, and then you will be looking at some signs objectively. Like for example, if patient is giving history of dyspnea, and now when you examine the patient, there is raised CVP, or there is edema, or there is crackles, or there is pedal edema or sacral edema, or there is cyanosis, or there is clubbing, then it is telling you that yes, patient is going in the failure. Okay, so that's how you correlate it, the symptom which the patient is telling, and then you are correlating it with the signs. Like one of some few of the signs I have told you. There may be postural hypotension, there may be tachycardia or bradycardia or some murmur, but you are correlating it. You are not taking it isolated. You don't have to sell anything isolated. You have to correlate it, because at the end of the day, whatever information you get, at the end of the day, you have to decide. Either you have to proceed with the surgery or defer it, optimize it. Like you find that you have an elective surgery and you find that patient is dyspneic at rest, and then you auscultate, you find crackles, or you find severe cough, or you find and you did the ECG and now you find ischemia, then you will be looking at that the patient needs optimization. Either you will be giving medical treatment, or you are doing the surgery. Okay, or for example, if there is heart failure and there is no obvious ischemia at that time, You will be giving some diuretics, you will be giving some vasodilators, you are giving some inotrope, you are giving the heart some strength, and then when the symptoms are improved, only then you will be going to the surgery. But all these rules are crossed and you have to proceed if the surgery is urgent. In that scenario, you will be having extra monitoring. You will be using the technique in which you actually try not to increase the pressure on heart further or minimize the pressure. Okay, so that's what is the whole concept of doing preoperative assessment, and that's how you should be reading. If you open a book and you try to read from the first page of cardiovascular system, you will die in between. After reading 1 or 2 pages, you will be lost somewhere. But if you correlate like that, I guarantee you will enjoy that. If you are studying valvular heart disease, you start from the basic heart function, and then you go it. And then and another advice: don't try to read valvular heart disease as separate, heart failure as separate, ischemic heart disease as separate, hypertension as separate. There is no separation. They are totally correlated. If you don't know, if you don't read this topic as a compact, you will have some missing concept. And I only understood when I correlated all these things. Like you should be knowing the cardiac cycle in the form that what are the changes occurring in different chambers of the heart during the cardiac cycle. Okay, and then you are correlating it with the pathology, that if, for example, if there is aortic stenosis, the left ventricular pressures are going high. If there is regurgitation, there is back pressure and the left atrial pressures are getting high. Okay, so this is how you will be correlating. If there is tricuspid regurgitation, the CVP will be high. Things like that. Okay, so that is how to target any topic. Okay, and then you will be going from that thing. You should be reading cardiac monitoring. You should be reading cardiac investigations, because and just correlate now, just like we get the example of Gyneops a few moments ago. If you are preparing any exam, yes, some exam will be finishing on the basic sciences, so you will finish here, but still they will be asking you some relationship between the basic sciences and the clinical sciences. Okay, and that will be exaggerated if you are appearing in exam which is mainly clinical sciences exam. But still you should be knowing the basic sciences, because without basic sciences you cannot understand. And then next step will be monitoring, intraoperative monitoring. Like, for example, in some patient you are only doing non-invasive blood pressure monitoring or ECG as part of standard 2 monitoring. But next step will be, there is a patient with valvular heart disease with high PA pressures. Now you need to have some further investigation monitoring. Like you might have pulmonary artery catheter in some condition. You might need cardiac output monitoring in some condition. You might need invasive blood pressure monitoring. Definitely. You are monitoring CVP, pulmonary artery catheter, cardiac, as I told you. Okay. So because it will be giving you a picture about systemic vascular resistance, volume status, cardiac contractility. Okay. That whatever you are doing, you are trying to see intraoperatively whether this patient needs fluid. For example, if you are having a patient having only invasive blood pressure monitoring, like arterial blood pressure monitoring, okay, still how you can pick it, Mahjabeen? Would you like to tell? Or maybe Amina? And that, for example, if you want to differentiate, patient is going in hypotension, and now you want to differentiate whether this patient need vasopressor or fluid or inotrope. How will you differentiate on the basis of monitoring?
Sir, on the basis of monitoring, we have to see other vitals like the tachycardia or the saturation, also the saturation. If there would be a CVP, then we have to monitor CVP too. When we monitor all these parameters and vitals,
Like, for example,
we
I
get
give you a data. Blood pressure is 80/40. Okay.
ठीक है.
There is a choice to decide between whether you should be giving vasopressor or fluid or inotrope.
Sir,
How will you choose? In which
uh,
patient you will give fluid? In which patient will you give vasopressor? And which patient you will give inotrope? And how will you correlate with monitoring?
sir, if there would be a tachycardia and there would be a picture of hypovolemia, tachy with hypotension, and the mean would be more than 65, then we will give him the
Any other thing?
fluids,
Any other thing?
and the CVP is lesser than 12 or 10.
No, no. Okay, okay, fine. CVP can misdirect you. Okay, there is something more which you can get from invasive monitoring. You will be looking at the inferior vena cava
Invasive,
collapsibility. If you
yep.
just put a probe and you see the inferior vena cava is collapsible, then it means the patient needs fluid. But in the same
Yep.
patient, if you see that a vena cava is already dilated, then you will not be giving
Yes,
fluid.
sir.
You will be giving
Yes, sir.
inotrope.
Well, inotropes,
Okay.
yes.
If, for example, you have cardiac output monitoring and you are seeing at SVR and SVR is low, SVR is surely telling you that SVR is low. You will not be giving, you will be giving fluid as well, but actually you are starting norepinephrine. Okay.
Yes, sir.
Because you know that now this patient is in systemic, there is vasodilatation. There is a low SVR. You will be treating the cause of low SVR, but you are handling or coping the low SVR as well. Okay. So that is how I'm just giving you an
Yes, sir.
example. CVP is one of them. Okay. But actually,
Yes, sir.
there are certain parameters which you can get from other things like stroke volume variation. I tell you. Okay, stroke
Okay.
volume variation. If SVV value is getting higher, it means the patient's vascular system is not full. You need to give some more fluid. Okay, and then
Yes, sir.
also with the T, when you are putting T or even the transthoracic, you are just getting an answer whether the contractility is good or no. If you see that contractility is low and there's certain history which is suggesting it, then you will be giving some inotrope as well. And in the same,
Yes,
now we are
sir.
discussing the same scenario. Now you saw that they put the echo, okay, or there is you are monitoring the specific ECG leads, modified chest limb leads or whatever, CM5 or CB5, and you saw that there is some ischemia going on. Though you are focusing towards reducing the heart requirement of oxygen by decreasing the heart rate, for example. You are giving
Yes, sir.
some beta blocker, or you are giving some, for example, in the same patient, you are suspecting that patient is going towards ischemia. You may, according to the scenario, you might need to have 12 lead ECG, and you might need to have cardiac consultation. You may be considering to defer the surgery or minimize the surgical extent and treat the patient on the line of ischemia. You may be needing to give aspirin, beta blocker, or anything like that, which is decreasing the cardiac workload. Okay. Myocardial
Yes, sir.
oxygen demand supply ratio you have to maintain. So if you have this picture and now just concentrate on any question, I guarantee you, you will have a better concept to answer or tackle this question. But if you
Yes, sir.
try to make a separate window by cramming a specific answer of a specific MCQ from a specific book, you will be in big trouble. Okay. Yeah, I hope you
Yes, sir.
understand. I hope you
Yes, sir.
understand what I'm trying to say. That in the same patient, so now we have the same patient. Now you see that there is some electrolyte imbalance going on. So that is you are getting it from the ABGs. The cause of hypotension may be, for example, there is low calcium, or there is any other electrolyte imbalance which is causing that thing. You saw the patient and now you saw that bicarb is, lactate is very going high. So it means it is
Yes, sir.
showing a poor perfusion. So you are giving more
Yes.
fluid. Okay.
So if lactate is high, then it would be a septic shock, and we would go towards the treatment of septic shock then.
Yeah, of course, that I'm just giving you a hint that lactate level in even patient is
Yes,
not
sir.
in septic shock. You gave
Yes, sir.
little fluid. You did not treat the
Mhm.
dehydration. Any patient or any patient you are
Yes,
dealing, and now you want to see whether you are well hydrating the patient. There will be some
yes,
clinical
sir.
parameters. You will be looking
Yes,
at
sir.
the urine output, but and the other thing will be lactate level. Okay. If there is
Yes,
no other cause, if the lactate is going high, then in a normal patient, this is maybe only a representation that you just need to give some fluid so that the peripheral
yes,
perfusion is improved. Okay. And in that scenario, you might need to decrease vasopressors, because sometimes Vasopressor themselves, if they are giving you are giving in high dose, there may be some anaerobic metabolism going on because of the ischemia which you are creating yourself by giving high dose of vasopressors. Okay, so that is how you correlate. Now you just think about what is the purpose of using ECG, what is the purpose of using end-tidal CO2, what is the purpose of using pulse oximetry, what is the purpose of using arterial line, what is the purpose of using cardiac output monitor. You don't do it just to play, you have to extract something. Okay, so this is how. Will you find any book mentioning this way of management? Give me that book and I will publicize it throughout the world. Just give me
No,
None
name
sir.
of the
me.
book is complete.
Sorry,
None of the book will
none
give
of
you
the book is
this much
complete.
information
So
and
please,
complete
please,
information.
please, that's what I'm trying to say, that there is
Yes.
no difference between you and me. Okay, why? Because you are also dealing, you are, all of you will be consultant, either you are already consultant or you will be a consultant. You are playing with the life of someone. Would you like
So
your dear ones?
you should write your own book,
No, no,
which
I,
can help
I,
us.
I don't want to write a book. Brother, I tell you something. If you have the ability, do you know who reached medical college? Are there ordinary people who read medical college? No. What portion of
Mhm.
the society of your country you are representing? Have you ever thought? No, you have never thought,
Mhm.
because you are being bombarded by the big names in front of you. Because if you think, if you just make yourself depressed or impressed, both of them are dangerous. Try to be not neutral, try to take a chill pill. If you don't know the subject in this way, you will be embarrassed, I tell you. There is no shortcut in life. If you try to cram MCQs books, and I know a number of people who are unable to pass the exam when I was appearing. There were some of my friends who were appearing in the exam since 2011. I started in 11, and Alhamdulillah, I passed in 13. I suffered a lot. I had no, if someone asked me these questions, I would be staring at him like like a damn fool. And I am the same person. Nothing has changed. I have the same I'm same Zishan. But the only thing is that I have thrown away that bloody Morgan, who's Morgan Sharif. I have just thrown away the worship of any specific book. I have just tried to use my own intelligence. Okay. And that's what I want you to do. If you are out of this myth, if you are out of this mystery, only then you will be able to learn. The choice is yours. You can give you can give yourself a lot of trauma, or you can come out of this misery and respect yourself. Because you see, remember one thing: no examiner is your enemy. Though no exam system, at the end of the day, even if I criticize like anyone on CPSP or universities or whatever, you cannot change them. Okay, you cannot throw a bomb on them. You have to live in that scenario, and you can only change it by from your side. Can you get any find any escape? No, you cannot. So you have to live with it, and I guarantee you that if you change your approach, you will never fail. The exam, just I will quote Three Idiots. What was the message sent in that movie? That you get the knowledge, the exam will follow you like an idiot. Okay, if you try to follow exam like an idiot through only by a book, I guarantee you it's not the solution. Okay, it's not the solution. Just try to get the knowledge, and a time will come that exam will be at the tip of your feet. I guarantee you. Okay, so I think, I don't know what message I have given to you, but the message I am giving to you, let's try to correlate the topics. Okay, you cannot read some things alone. You have to correlate them, and then when you correlate, then it will become very easy. Still, I tell you something. There are some difficult things which they will be asking you more in the basic sciences exam, is the correlation of CVP, ECG, and cardiac cycle. This is actually pure basic stuff. If you have the concept, still you can manage the patient. But in the basic sciences exam, they will be expecting you when the P wave comes, when the A wave come, and when what is the stage of cardiac cycle it will be. What will be the pressure status in left ventricle when P wave comes, like things like that. So sometimes it is difficult to explain. That is the only additional thing when if you are appearing in EDA IC, for example, or if you are appearing in primary FRC, or if you are appearing in MCAI exam, you will be needing some more details of these things. Otherwise, the basic concept is the same. But if, for example, while studying for FCPS, if you have the concept like that, who will fail you in an exam? Just tell me. You will not miss any question. I guarantee you. Okay. So that is what I wanted to tell you. And any questions? So my message is that you read the topic from articles. I have arranged all the articles, and I believe me, I'm not getting any royalty. Rather, I'm paying for them. I remember one day I downloaded all the articles, and after some time I started having severe headache because I don't find anyone to help me. Like if I invite any first year resident, uh, nobody is in my domain because I am not in Pakistan. I'm in Saudi Arabia. I'm not in a clinical teaching setup. I don't have any resident with me to help me out. And whatever I'm doing it all alone. Okay. And I invite all of my seniors, colleagues, my friends to help me out. And because I'm not running this show for any personal gain or any financial gain. Okay. This is purely for you people. So like Mahjabeen, if you, I will be very happy if you just be in touch with me and just help me out. You will be the best beneficiary, and other people may also get benefit. Okay, so because that's the problem in our country, that we only think about ourselves, and then when we are only think about ourselves, actually we are not getting helping ourselves as well. Our own self we are not helping actually. Okay, so I
Yeah,
think
I
a
will
lot of
try to help you
uh,
out as much
uh,
as I can.
yes, you just drop a message, and because I was really impressed by your approach last night, and when you were answering the questions in the pre-operative assessment, I guarantee you a number of people who have finished their training, they will not be able to answer the questions which you were answering. Okay, so mashallah, you are doing well. And one of my friend who is running away from this way of spreading the knowledge, but actually he is my teacher, and he was, by the way, he was 5 years junior to me. He's working in PKLI. I try to catch him a lot of time, but I'm not able to catch him. And one of my friend, his name is Awais Tahir. He is working in Medina. He's also away from it. And one of the third of the friend is still doing FCPS because he approached this goal by some other way. He was only all the people who are doing MCPS. He is a role model for them. He did MCPS, and on the basis of MCPS, he at that time there was a window. He appeared in EDA exam. Okay, and then after EDA passing EDA IC, he was eligible to appear in Irish Fellowship. So he did from MCPS, EDA, then FCI. Then he was lucky enough to get a training in FCPS. He did FCPS part 1. He got the training. Then he did intermediate module, and now he's appearing in final exam. Okay, so he reached there from the back door, but he has done all what we have done. Okay, so nothing is impossible. You can do everything. You just have to change your approach. No exam is, believe me, nobody is out ineligible to appear in an exam. Everyone can do it. It's only your approach which will dictate you. Okay. Any question before we finish? Because now the discussion has become philosophical rather than academic. So I think I will not
Can you
take.
please send that message regarding the topic, daily topic, a little bit earlier so that I can review it
Yes, this
before
is
that
this is a
lecture?
good point, but thing is that sometimes it is possible, sometimes it becomes not impossible for me. Okay, because actually yesterday night I told everyone that I will have a session, but in the morning I forgot to send the link. Okay, but you can say that on weekends I can I will take class at this time. And in the week, because it is a weekend for Saudi Arabia people. Okay. Friday and Saturday
Okay.
is weekend in Saudi Arabia. So usually I I have fixed the time. I have tried to fix the time at 10 p.m. Pakistan time and 8 p.m. Saudi Arabia time daily, 1 hour or half an hour. And you will find some of the topic almost daily. If I'm busy somewhere, I just don't send the link, but usually I'm doing it. And in collaboration with Dr. Amir Furqan, we are trying to make a regular session on every Friday or Saturday. On every Friday or Saturday, most probably from next Friday, it will be on Friday. This time I was not busy. I was not free at night. So tomorrow there will be a session. I invite all of you with the things which I have discussed. We will be peeping more in detail in the form of cardiovascular system. Okay. And majority of the recordings are there in the YouTube channel. You can follow the playlist and you will find a number of things, and anything if you don't understand, you can just drop a message on WhatsApp and I will try to answer them. But my message is that you study retrospectively, you follow the articles, you try to find out what are the buzzwords in that topic. And that's what I have tried to do in a folder over there in the topic wise question folder. Okay. I can just a second before we finish. I will again share this screen for this link so that you because before the articles were in other link, they are still there as well, but actually I just arranged them year wise and topic wise. This is a separate link. Year wise there are 3 sources. This is anesthesia and critical care source, another one. This is anesthesia tutorials, and this is BJ education. Its previous name was CEA CCP. Okay, so you can and then these are all arranged year wise. Okay, so even you will find up to March, April edition has also come. So I have even downloaded and put it them there. But sometimes you see now what's the problem? I have to throw them in the topic wise as well. Sometimes I'm unable to do it. It's very hard. I have to copy this article and I have to throw this to this folder in the topic wise. Do you think it's an easy job? Believe me, it's not an easy job, and I have made it possible. I don't know how I have made it possible. And still, unfortunately, nobody is interested in looking and opening the folder. Everything is there. I have tried to make it as helpful as possible. You will find all the topics which you are required to study. And if you don't find, you can write either abbreviation like this one, or for example, like whatever you say, scoliosis. Okay, so you will find it. If someone
So
doesn't,
can you please send the link of this drive
I send
in
it
WhatsApp group?
at least once a week. At least despite nobody looking at, you are in which WhatsApp group?
Anesthesia knowledge.
You
I have
can you
joined
see?
Sir,
you
we
three
are
to 4 days
feeding.
ago.
Huh? Can you see how many anesthesia knowledge group can you see? I'm not getting any pennies for them.
Yes, sir.
I'm just showing them. I'm showing them for you to think about it, that if I am investing time for you, you don't have even time and energy just to even look on the link. Just tell me, is it fair to me?
No.
Okay. So, and for example, another for active Pakistani people, if you just want to search any link or anything which is shared, you can go. It's the similar will be in your mobile as well. Okay. You will go in the media. Okay. And in the media, you will find the pictures. Here you will find the attachments, and here you will find the links. Okay. Any link which I shared, you will find it here. So you see, I have sent it even 1 day ago. Article World, Zishan anesthesia data, the link for my YouTube channel. Okay. This is and this one way, or even if you are busy enough not to do this, mashallah, you can ask me anytime. I will just say few words like a mother-in-law or sister-in-law, and I will send you. Okay. So you can search like that as well. like this. You will I think you should be finding like this as well. Like you can search in a number of ways, or another thing I will tell you, that for example, if this is the link, and you want to make this message, it's easier to do it. Just a second, because there is a way to star the message. Yes, in the mobile you can do another thing, that you just click the message, select the message, and you will find an option of star message. In the mobile, when you will do it, you will find a star over here, and then you can do the star message. When you do the star message, then when you go here, and you will find the starred message. Okay, and you will find it right there. So if you want to use them, you can use it very easily. Okay, so I hope you got it.
Okay.
Okay, so thanks a lot. And any question, you anytime, you are welcome. And I just need your help. Everyone, just respect yourself and just think that you can do it. Okay. Okay, everybody. Who is this Daniel Gakwa? Are you from some African country, Daniel? Yeah, can you hear me, Daniel?
Hello, yeah, I'm from Nairobi.
Yes. How are you? It's
I'm
an
from
honor for
Nairobi.
us. It's you are from Nairobi. Okay, so it's
Yeah.
it's an honor for me for you to join our discussion. I hope you got something.
Thank you. I've gotten something. Thanks.
Okay, so all of you are welcome. Okay, and my country fellow are busy, and someone in Nairobi is listening to us, and all others to whom I sent the link again and again and again and again, and then they are saying, oh, this is for Viva. No, 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 this is for, sir, we will take the knowledge someday, but first of all, we have to pass the exam. Then enjoy the failure. No problem. I have nothing good. I will not take pictures from you with you and post on Facebook, which most of our respected supervisors are doing. I'm sorry to have this comment, but it's a reality. Okay. I will be very happy if all of them invest their time on the baseline. They go to the operation theater. Please, I will request all of you, don't be afraid of your supervisor. Try to make him come to you inside the OR, and teach you on the patient head. Don't be afraid. He will not kill you. I tell you, I guarantee you, no supervisor will kill you. And even, for example, if he is angry at it, don't bother about it. Make this move. Ask your supervisor to be on your patient head to teach you. It's his responsibility. It's his responsibility. He is supposed to do it. He is some I talked this to someone, and that person said to me that they are not being paid. Oh, no problem. If they are not being paid, they are not being forced to become a supervisor. It's their choice. They are enjoying a lot of things because of being a supervisor. So why not you catch them and bring them on the patient side? Because no teaching occurs in the air-conditioned room with a cup of coffee. Anesthesia teaching occurs on the patient side while he's looking at you what you are doing. What is your approach to touch the patient? What is your approach to intubate? But I can guarantee you, I will really sorry to say this thing. Number of people don't know even how to do this, the scrubbing, how to clean the area. They are starting from that area and they are going side and then coming back, which is the wrong way. And why they are doing it? Because nobody pointed them out. And they have learned that thing, and they are doing it even after 20 years of their practice. I'm not criticizing for any specific person. I'm just, this is your problem. This is your fault, because you people are afraid of that supervisor will get angry. No, even if he get angry, he will get angry at any point. So let him get angry by asking questions. This is his responsibility to teach you. He has owned you. You are representing him and he is representing you. So he cannot run away. It's his responsibility. It's his responsibility to make sure that you are being trained by hook or by crook. It's your fault that you don't ask the questions. Okay. Sorry for this. If anyone is hurt by this comment, I'm apologize, but I don't care, because this is what I want the juniors to learn. Stop being afraid of your supervisors. This is a message especially to people in Pakistan. Okay. Thank you. Bye bye.